Now, of all the topics here, this is probably going to be the one that gets the least amount of thought, and it's vascular disease in women, but it can be equally as problematic and very lethal too. Other than what Dr. Pastore treats with heart disease, this is probably the most leading lethal disease for, or it can be one of the can be a lethal disease for women for a multitude of reasons. And I'm going to briefly talk about the risk factors. It's going to be very redundant. A lot of stuff that Dr. Pastore said. Same things that are risk factors for heart disease are same thing for arterial disease. The big ones I want to focus on are smoking. And I'm going to echo something that Dr. Pastore said, and I tell my patients this on a consistent basis. I say if everyone tomorrow stopped smoking, I probably would be out of a job. If it wasn't for my veins, we'll talk about that later. But that really is a true fact. And it is astounding that the people come in and continue to smoke. And I'll have women, young women, who've come in, have had bypass of amputations, and they still smoke. And it's a sad thing. And I'll tell you, I tell patients all the time not to smoke, but one of the roughest times is I saw a patient came in, it was a mother, went into the room, and she had a gangrenous foot, and she had continued to smoke, despite multiple warnings not to do so. And she's sitting in the room with her family, and her kids are there, and they're younger kids. I mean, they're in their early teens, 7, 8 years old. And I have to sit there and tell them that I'm going to have to take off their mom's legs. And the look on her face and their faces, it's heartbreaking. But again, people just won't stop. They won't stop. And if any of you smoke here, just stop. I mean, I can't tell you anything else other than just to stop. Other thing, and this is kind of going off our first talk, obesity. It's a, no pun intended, it's a growing problem in our country. Anytime you turn on the television, you look at a newspaper, you'll see that we are becoming a fatter nation. And we know why, but we're not taking steps to change it. Things like portion control, very simple, less in and more out. That's what you have to do. Exercise more, put less in your mouth. Other things, diabetes, again, that's something that can be controlled if a big cause of diabetes is overeating and obesity. And so if you manage that, you're going to, on the back end, get control of your diabetes. As far as the actual, what I tell people when they say, what do you do? I say, well, I operate on all the blood vessels in the body except for those in the brain and those in the heart. So I'm going to just focus on a couple ones that I really want you guys to have a take-home message about. And I'm going to go top to bottom. I'm going to start here at the carotid arteries. One of the things that we treat people with is carotid artery stenosis. And it is a problem that, if overlooked, can be significant. You can have strokes, and strokes can sometimes lead to death, or in the very least can lead to significant disabilities. What I would tell you is if you have any of those risk factors we talked about for cardiac disease, they're going to have the same risk factors for carotid disease, and it's something that your primary care doctor should at least, in the very least, put a stethoscope to your neck and listen. And what they're listening for is something called a bruit. And what that is it's very simply when you have abnormal flow through the blood vessels, you're going to develop a noise. It's called a bruit, and that's one of the first tip-offs. And then we follow up that with an ultrasound, which is an easy, non-invasive test. We do them in our office, and that can tell us if you have it, how severe it is. And depending upon the severity of it, will depend on what we do. If it's not that bad, we'll watch it. We'll try to do some risk factor modification, maybe some medications. If it's significant enough, you may require surgery. I will tell you this, a couple different ways to fix this. We can fix them with stents, which is a minimally invasive way. But the indications for that, there are certain people that fall into it, and it's a small group. That's going to be someone who's had neck irradiation before, if they are not a candidate from a heart perspective to undergo general anesthesia, or if they've had a carotid surgery done before. Otherwise, we do it the old-fashioned way. Make an incision in your neck, we open up the artery, we clean it out, put a patch on it, close it back up. Sounds simple enough, but it's one of the scariest operations I do, because I tell patients, hey, listen, I'm doing this surgery to prevent you from having a stroke. By doing this surgery, I can give you a stroke. But again, it's one of those things that we can watch out for. And I'll tell you, no one wants to have a big incision on their neck, and people get really concerned about that, but I will tell you the neck is a very forgiving area. And if you see some of my patients that have had the carotid surgery, sometimes it's hard to even notice they've had it done. Next, let's talk about the aorta. Now, does anyone have any idea what Lucille Ball, Albert Einstein, and Joe DiMaggio have in common? No? Yep. They all died AAAs. But the thing is, we don't hear, the thing is, if you list of all the people who, you list famous people, majority of them are men. But we are seeing an increased risk in women and also increased mortality. And the reason why, and this is the same thing for pretty much all peripheral arterial disease in women, is it's thought to be a disease of white men. But we're finding out that that's not the case at all. And the thing is, you need to be looking for it if you have a family history of aneurysms, if you smoke, if you have diabetes. Those are things that are tip-offs. Now, again, you can try to pick these up with physical examination by palpating the abdomen, but only about 30% of them will be fine on physical examination. And this is compounded by the problem that we talked about earlier with obesity. The more obese we're becoming, the more difficult it is to palpate these aneurysms. Again, fortunately, this is another disease process that can be easily evaluated with ultrasound. Again, we do it in our office, and if we're looking for you and we think you have the risk factors, especially family members, then you need to have it checked out. Next, I'll move down to the legs. And I'm going to talk, the remaining time I'm going to talk about leg pain. There are two main reasons why I treat patients with leg pain: arterial disease and venous disease. In arterial disease, it's very easy to kind of differentiate the two, generally easy to differentiate the two. If you come in and you say, listen, I walk, I have pain, I stop, I sit down, pain gets better, if I can walk some more. That generally indicates to me that I need to start looking down an arterial path for the pain. Same risk factors as we talked about before. Physical examination can be very telling. If you have sores, we can't feel the pulses in your feet, you have wounds that aren't healing, these are all indications that you have peripheral arterial disease. And unfortunately, this is, women have poor outcomes with peripheral arterial disease for a multitude of reasons. One, majority of them are asymptomatic. And I don't know why that is. I guess maybe just proves that women are tougher than men, that they don't complain about that much. The other thing is because we're not looking for it as much, because we have the perception that it's a white man's disease, that by the time the women present, they're a little farther down the road. And they end up doing poor as far as surgical success, outcomes, and amputation rates. Then lastly, I'll talk about venous disease. And that normally looks like people say, if you have a big varicose vein, you have venous disease. If you have spider veins or reticular veins, which are that little dark blue vein you can kind of see there, that's also venous disease. And then a lot of times people will have, my legs just ache. I lie in bed and they just feel restless. I can't get comfortable. These are all things that make me think, okay, maybe this is venous disease. Again, diagnosed with ultrasound. And it's fairly easy to treat as well. We can do compression stockings, but a lot of patients won't tolerate that because I tell them, listen, we live in Florida, they're hot, they're not stylish, and they're hard to get on. The other option we have is we can do laser procedures in the office called EVLT, or endovenous laser treatment. Very simply, it's about a 20-25 minute procedure where we close the veins down in the legs, and then it alleviates a lot of those symptoms. It also will treat some of the spider veins that women have, and if not, you can come back and do the sclerotherapy. The one thing I would warn you, there are a lot of people out there that do sclerotherapy, but if you're not looking for that underlying venous reflux and treat that with the laser, you're going to be pouring your money into that because it's going to keep on coming back.